let me play prosecuting attorney for a minute.
Okay.
Somebody's admitted with perhaps decompensated heart failure, and they're on the regimen that you said should be switched. Do you switch them in the hospital?
You can.
That's not what I asked. Do you? Should you?
You should only at the point where they are no longer acutely decompensated.
Okay.
So somewhere during the hospitalization, if the patient goes from becoming acute to chronic, and there's no perfect line in the sand, it could be an eyeball test from the door, when that patient is no longer acutely decompensated, is a good opportunity to potentially switch, especially if you may have 36 hours left in the hospitalization. It's a good time to wash out the ACE inhibitor potential.
Got it.
And I would also add that at the time of hospitalization, you can also draw labs and make sure the patient is stable when you're initiating Entresto or the ARNI. And there was actually a study that showed medications that are continued on just prior to discharge are those that patients will continue to the outpatient setting. So we want to make sure that we tune up those medications just prior to discharge before sending them out.
I think it's a great strategy. However, I have to be honest and say this wasn't what we studied in Paradigm. And there's no clinical trials data yet. There is a trial going on currently called Pioneer, in which patients are being randomly assigned to either the ARNI or enalapril after they were hospitalized and then became stable. So there will be data on this, but in the meantime, I think that as clinicians, we can use our judgment. If a patient has been stabilized, we feel they're about to go home or within a few days of going home, I personally think that's a great time to start a new medication.
Let me push back a little bit, though, because I think one of the challenges also, we've talked about a lot of medications that patients have to go home on, and the hospital stay is an attractive time to make some of those changes, but we also have to be sure that when patients leave the hospital, there's adequate surveillance of the potential for adverse effects. And the fact is that not every patient can get every medicine we can deliver to them in the hospital. And I think particularly for some of these newer medications, one of the questions is what's the cost at the point of care to the patient, which may be different for different payers. And so one of the challenges with starting medicines in the hospital, and this is not peculiar to heart failure, is that not all those medicines are uniformly available to every patient in the outpatient setting.
So Peter, Akshay just used two words that we've not used before in this program, adverse effects. So one of the things we didn't really talk about, we talked about the efficacy associated with sacubitril valsartan, and we hinted that this is a medicine that is a potent blood pressure lowering drug, and so hypotension is something we have to worry about. But it's also important to note that there are other adverse effects that people get when they're either put on RAS inhibitors, and this includes renal dysfunction and hyperkalemia. There was actually less renal dysfunction and less hyperkalemia in the sacubitril valsartan arm in Paradigm than in the enalapril arm, which I think is very important. It's especially important if you also want to use a mineralocorticoid receptor antagonist, because as we know, those drugs increase the risk of hyperkalemia for certain. And Akshay has actually published a paper showing that if you're on both a mineralocorticoid receptor antagonist and sacubitril valsartan, you have a lower risk of hyperkalemia than if you're on a mineralocorticoid receptor antagonist and enalapril. And you have a better outcome to boot.
Are physicians in the community sufficiently aware of these new drugs, of the ARNIs, for example, that you feel comfortable sending patients out on them to the care of a primary care doctor?
I feel like we have to do our homework before we send patients out.
What does that mean?
So Akshay mentioned making sure that the medication can be paid for once the patient leaves. I think that's number one when starting a new medication. When they leave, is their insurance going to cover it, or are they going to be able to afford to pay for it? And then number two is we're sending the patient out the door, who's catching them on the other side? So is there a plan for immediate follow-up, and immediate meaning within the first 2 or 3 days, immediate in person within a week, And that communication needs to be in place between us in the hospital and whoever is managing in the community.
So this is the classic transition of care.
Correct.
This is, they're in our care, the specialist care, and now they're going out. And somebody has to shepherd this. right?
Correct.
So who does that?
We have to,
Okay.
together. There's no, I mean, there are people that do this as part of their jobs in terms of discharge planners. But we as clinicians, it's our responsibility to make sure that they land on their feet on the other side.
Okay,
And in fact, a lot of hospitals are in fact paying for nurse practitioners and pharmacists to meet in the clinic 1 week after discharge in order for these patients to make sure they're followed up with cardiology, their PMD, and they basically are paid to reduce 30-day readmission rate.